thank y'all all for being here with us this evening. We're really excited to have this conversation with you all, introduce you to the work we've been doing and kind of bring you along for the ride. My name is Ashley. I am the Director of Adult Programs at the Cerebral Palsy Foundation. And joining me this evening, I'll let them kind of do their own little intros if they want, is my colleague Katie Gastra, who does digital strategy for us at the foundation, and Dr. Mark Peterson, who's with the University of Michigan, and he is our lead researcher on our Clinical Practice Guidelines project, which we're going to be telling you all about this evening. So happy to have these two here with me.
Thanks, Ashley. Happy to be here.
Yeah, thank you, Ashley. Can you guys hear me okay?
Yes.
Great.
And just to preface, the goal of this conversation series is really to be quarterly. We'll continue throughout the year identifying topics that our community cares about. So keep an eye on our Instagram for any polls or Q&As on things like that. We'd love to hear from you. All right, just going to move forward into this press.
We'll kick it off. So sort of what we're going to run through this evening is we're going to give you a project overview. I know probably most of you who are here have been following along with us on social media, so you probably have some sort of a gist at this point of what we're doing, but we are going to overview the project, and then Mark is going to talk through kind of what led us to this project's formation and how we got here with the research. Katie's going to talk about what we are doing very intentionally around how we are going to be sharing knowledge with you all as this project continues to progress. And then we'll have a time for questions and discussion at the end. So we'll get into it. All right. So we've talked a little bit about this on social media. We've touched on it a little bit, but I do like to kind of preface every conversation that I have about CPGU, which these days is a lot and frequently, is that this whole project was driven and guided by the community from the very beginning. Mark, jump in with me on the history here, but y'all were talking about this as far back as like 2019, 2020, and then the ball really got rolling in 2021 when I was brought on at the foundation. That's kind of what I remember. Is that in line with what you remember?
I mean, it's in line with kind of the state of the field, really, because very little focus previous to 2018, 2017 had been on adult or lifespan initiatives. And so, you know, we started to do some work in the adult and lifespan space. And it has grown significantly over time since over maybe the last 10 years. It really has grown up, so to speak. And that's where my involvement with the foundation started.
Yeah, absolutely. And we did do a pretty major survey back, it's been some years ago now, so probably something that we'll be looking to redo soon as sort of we're advancing through other stages of this project. But our community survey, really one of my favorite takeaways from it was that it told us that for both parents of children with CP who are going to grow up to be adults, you know, and adults with CP, finding out information about aging with cerebral palsy was a huge priority for both of these groups of folks. So that's really what informed the baseline necessity of this work, is also a need for, not only do we need to know about aging, but we need to be able to access quality specialized care as we do age. And again, you can see that parents and children were kind of united on that front, which is great. So as we kind of asked a central question of like, what is the problem that we're trying to solve? And the big picture problem is the entire healthcare landscape for adults with CP. Across the lifespan, it is, I don't know, severely lacking almost feels like a euphemistic way of putting it. Like I'm not sure that that's even quite frank enough, but I know I'm preaching to the converted here, but we all know this. We age out of the pediatric system and we're left with absolutely no path forward, no guidance, no oversight. And there are a lot of gaps in the research that have either been identified already or we are currently identifying. And that, coupled with a lack of access, just leads to providers that aren't equipped to provide the right care. So that is what we are trying to change, big picture. We call these pillars, I don't know, tenants, buckets. They have several different names, but the cornerstones of this project, so to speak, that really are happening concurrently, though at different levels, I will say, is knowledge translation and dissemination, so knowledge sharing, research, clinical implementation, and then advocacy and policy. And for tonight, we're going to focus the most of our conversation around the two pillars that are most fully underway at this time, which is currently research and knowledge translation and dissemination. The other two are chugging right along as well. And I anticipate that as those other two pillars develop and continue to grow, we will have follow-up conversations to this one where we are bringing the community into what's happening on those fronts as well. But for tonight, we're going to focus on the guidelines and what we're doing digitally. Well, of course we do. I feel like I hate that we even have to say that, but in our current environment, I feel like it never can really be repeated enough. It's not like this work and a standard of care that we're trying to achieve. Like, we're not doing somebody a favor. We're not going above and beyond. We're literally just trying to provide an equal standard of healthcare, which should be the bare minimum. And in 2023, towards the end of that year, when this project really started to get going, we did another community survey that was specifically focused around adult healthcare. And we used that survey to inform what domains or focus areas that our clinical practice guideline would center around. And we asked a variety of questions in that survey. We asked folks, are you receiving care in this area? If you are, what modality are you receiving the care through? What's your preferred delivery method of care across all of these domains? And we had a pretty big response in a pretty short window of time, and it was 79% adults, also accounting for parents of children, parents of adult children, and clinical providers and research. I believe researchers also, there were some answers. But all of the focus areas of our guidelines, which we're going to get into here in a little bit, were deemed, like on a scale, as very important to address. And of course, just like anyone else, most folks' preference was that their first line of care be their primary care provider, followed by specialty care, followed by community-based model, and then also telehealth. So really enlightening and really affirmed to us that we were on the right track with the guidelines. And the purpose of these clinical practice guidelines, which are in the works as we speak, is to establish a standard of care for adults with CP that sits at both the primary care and the specialty care level, so that there can be education and an identified standard of care amongst providers, so that we start filling in some of the gaps with this lackluster care. It's also an empowerment tool for us, right, as adults with CP, that we are equipped with a resource that should we be going to see someone new, we can take this resource to them and be able to reference it and advocate for our own standard of care and what we deserve. So we've assembled a pretty sweet, if I do say so myself, international working group of really, really not just smart folks, but folks who really care about adults with CP accessing care. Like, bottom line, that is why all of us are doing this. Most of the people who you see right here are doing this work on top of their regular everyday jobs, because they believe in it that much and they think it's that important. And so we are in the process right now of doing systematic reviews across each of these focus areas, which each systematic review will inform the development of the written guidelines. So we're looking at pain, we're looking at musculoskeletal health, gastroenterologic and hepatic health, mental health, sexual and reproductive health, nutrition and endocrine health, neurological and cognitive health, cardiometabolic health, respiratory health, and renal and urological health. So Mark's probably going to touch on this some more as he talks through these sections, but we really are taking like a holistic, whole body systems approach to healthcare. We are tired of CP. Mark and I both especially feel like super passionate about this. So you will hear a good bit about this, but we're tired of CP care being distilled down to muscles and bones. It is so much more than muscles and bones. We inhabit whole human bodies. So it only makes sense that we are looking at the whole body in our approach. But with that said, I'm going to turn it over.
Thank you, Ashley. Do I have the ability to control the slides or no?
No, Katie's controlling them. So we'll just
Yeah,
let
you'll
her
just
know.
have to
All right,
say next slide.
thanks for that introduction. That's a really nice introduction to the project and the work that we're doing. And honestly, I think it's not just a mission to change the landscape of clinical care and healthcare for adults living with CP, but to not just change that to being a holistic and whole human being, but also to change the paradigm that still exists in our country and other countries, that CP is a pediatric disability, because now there's more adults living with CP than there are children. So it is really, really important to develop this work and develop this project, and also then inform our clinical colleagues, public health advocates for advocacy of change for the healthcare landscape. And so thanks for that introduction. And you can go ahead and change the slide. I'll just say next slide next time. So cerebral palsy, now we recognize it as the most common lifelong physical disability in the world. The reason why this change is important is because the CDC, Centers for Disease Control and Prevention, still defines CP as a group of disorders that affects a person's ability to move, maintain balance and posture, and refers to the condition as the most common motor disability in childhood. And as I said, yet at this point, there are now more adults than children living with CP in the United States, and that goes for pretty much all developed countries. So to define it as the most common motor disability in childhood does a huge disservice to the hundreds of thousands and millions of adults living with CP. And in fact, I have talked to people, not just Ashley and Katie, but other folks around the world who have said essentially their physicians don't know anything about CP because they were not a pediatrician. So to me, as a not just a scientist and a professor, but I'm also a father of a son with cerebral palsy. It has been my mission, my life's work, my whole professional sort of objective to understand the natural history of CP across the lifespan. So, because advances in pediatric healthcare have meant that majority of children with CP survive into adulthood, life expectancy is now very similar to that of the typically developed individual without CP. You can change slides, Katie. And as you can see, my career has focused on the natural history of CP. Change slides. So, along with every single other human being, with age comes the risk of developing secondary frailty, physical dysfunction, motor disability, chronic disease risk, cardiovascular mortality, and then, of course, all-cause mortality. This is a general statement about the population, and it is not specific to the general population. It's also very applicable to individuals with CP. And yet, most individuals with CP have been seen by either a pediatrician or a physiatrist. And so as a result, they are then reduced, as Ashley alluded to sort of body parts. So my question has always been, what happens to children, adolescents, and young adults with CP as they transition through adulthood? The contemporary jargon being sort of like the wordsmithing of clinical colleagues, is they seem to experience accelerated aging. They seem to have premature frailty. That is premature or accelerated beyond what we would typically expect in a non-CP individual. There's risk for normal weight obesity, and they have exaggerated sedentary behavior. Let me change slides. So one of my first studies ever was to do a imaging study, essentially, when I first started at University of Michigan, to look at what's under the surface. I mean, we know kind of the classic CP symptomology, being things like spasticity management and bowel and bladder issues, and things that are related to obviously mobility and function. But as a physiologist by training, I really became fascinated with the idea that there may be differences in this particular patient population under the muscle, essentially, inside the human, inside the organs. And if that's so, I'd like to know what that is. So we did some imaging on a bunch of folks with CP and without CP, and you can go to the next slide. What we found, that's the difference between your slides and my slides, Ashley, is there's a slide behind that slide. That's okay, go back. I can explain it. So the imaging study showed that for basically pound for pound, individuals, adults with CP have a less dense muscle structure and bone structure and higher fat stores in their outer fat stores and inner fat stores, both in their intra-abdominal region, but also their muscle and bone, which places individuals, the first study to ever look at this, places individuals at potential risk for things like osteoporosis, for example, or diabetes, or cardiovascular disease. But at the time of this paper, nobody had ever studied that. That's okay. You can go to the next slide. That's perfect. Nobody had ever studied that. So, I mean, I scoured the literature. I talked to folks at the NIH and actually the program director at the CDC and said, like, where can I find data on adults with cerebral palsy from the standpoint of understanding their disease risk for normal chronic disease that we know to be true in the rest of the population? And they did not provide any information, because at that time, probably circa 2012-13, there were no data. And it just so happenstance, I was in a conversation with a health economist who said, you might be able to look at this particular source of data that is usually only available to health economists. We could maybe do a cohort study. And so for the first time in history, we pulled off a cohort study from a population representative sample of adults with CP as compared to adults without CP on various chronic diseases that we think are associated with aging or with chronic disease. And so we found that adults with CP had a pretty high risk for various not what we call non-communicable diseases, which are non-infectious diseases across multiple organ systems, including diabetes and asthma and hypertension, other heart problems, stroke, emphysema, and then joint pain and arthritis. And that was a first study, basically the first study in the world to show that adults with CP have a unique healthcare signature that is different than adults without CP. So then we wanted to tackle the idea that adults with CP have risk for early aging. And early aging, in my mind, and this is again clinical kind of jargon, my mind means that like either they have decreased function, increased risk of frailty, or increased risk of what we consider to be age-related, chronic disease. And so we looked at multiple chronic diseases in a clinical cohort here at Michigan in 18 to 30-year-olds. And you can switch to the next slide. And what we found was that adults with CP who are young, that's 18 to 30-year-olds, have a much higher risk of developing not only one, but multiple chronic diseases that we would traditionally consider to be age-related chronic conditions. So we shouldn't see things like osteoporosis and cardiovascular disease and diabetes in 18 to 30-year-olds. But what we found was that there was not just an increased risk, but there was an increased risk of having more than one of these chronic conditions. And so this went further than our previous study to show that there's some concern. There should be concern, and there should be some additional thought about what is happening to the whole person, what is happening to organ systems that are not just about CP. Okay, so making the case, trying to make the case or the story here that people with CP have the same organs, the same body structures, the same body physiology as everybody else, and we should be thinking about those things way before they present as an actual diagnosis. Go ahead. Yep. Okay, so there's a whole bunch of papers we've done over the course of the last 10 years across multiple organ systems and virtually every organ system to show, and again, this sounds scary, but to show that there is an increased risk for these non-communicable diseases. I recognize that the news seems bleak because it is, but at the same time, all of these, what we again call non-communicable conditions, are all preventable. Every single one of them is preventable. So with appropriate and coordinated healthcare after transitioning off a pediatric insurance scheme to an adult insurance plan, can be managed in a way that not only can they be treated if screened properly, but they can be prevented in the first place. So that is the genesis of why we decided that we needed to create this clinical practice guideline, because we don't want folks to have risk or have actually a diagnosis of these conditions because they're totally preventable. And so we've done various projects to create core outcome sets. Yeah, that's fine. To create core outcome sets for morbidity and multimorbidity risk to try to educate physicians. But as I'm sure everybody in the room can attest, physicians can sometimes be a tough audience and can be sometimes very stuck in their ways. So we thought, moving beyond kind of the standard research protocols, we will develop this really robust clinical practice guideline. And the foundation has been very, very generous and supportive of this project and has signed on to be a part of it. I'm going to highlight a few more papers that I think are relevant to literally everybody in the room, and myself included with my 15-year-old, is that, the more we started to do work in multi-organ system kind of problems facing individuals with CP, we started getting feedback from not just patients, but also parents and caregivers about mental health. And so we started to devote more focus in the area of mental health and pain management, because those two often will go hand in hand. Many people were asking the question, what do you know about mental health? And the only things that we could say as answers were, I only have information from individuals. I don't have information from studies or anything. So we started to do work in this space. And one of our first studies was done with a colleague of mine, two colleagues of mine, but primarily my colleague, Jen Ryan, who is formerly in London, but now in Dublin, Ireland, to look at risk of psychiatric conditions, specifically depression, anxiety in adults with CP. And what we found was that adults both had higher prevalent, you can switch to the next slide, prevalent and incident being they had a higher risk of developing depression and anxiety as compared to adults without CP. In that individuals, you can go out to the next slide, individuals who had co-occurring intellectual involvement, intellectual impairment had not quite as high a risk. So there is the first study here. You can go to the next slide. The first study to actually look at mental health disorders in this population. So when I say it sounds funny to me to say the first ever study, but I truly mean that was the first ever study, and that's going back only a few years. The very first study ever be published or looked at to consider mental health disorders in adults with CP. We followed up in the United States to kind of match this, or not one up it, but one up it, to look at what happens to adults with CP in the United States, and looked at multiple 37 mental health disorders in adults with CP as compared to adults without CP, after adjusting for certain things that we know to be contributing factors for psychiatric morbidity, including neurodevelopmental conditions. You can switch to the next slide. And then the next slide. And what we found was that folks who had CP, both men and women, had a higher prevalence or incidence of having or developing virtually every single mental health disorder. And for folks who had co-occurring neurodevelopmental conditions, which would include epilepsy, autism, or intellectual impairment, had a even higher risk. So it sheds additional light, and extremely important light, on the need not just to be thinking about mental health and psychiatric conditions, but be screening for these things, because these do not just necessarily arise in adulthood. There are certainly risk factors that can be addressed, targeted, and treated in childhood that may loom and be present in childhood, but then arise in adulthood. So, I often will get asked, well, why don't you care about kids with CP? Obviously, not knowing that I have a child with CP, that question is a fair question. And I, of course, do. What we know is about what happens in adulthood usually starts in childhood. So I have lots of conversations with pediatricians about our work, because there is a lot of evidence to show that what happens to you as you are in your 20s, 30s, 40s, 50s, 60s is something that would be started or looked at in your teenage years. So mental health is something that doesn't just pop up out of nowhere. It is something that takes place over a long period of time. I get emails like this all the time. This is no longer recent, but it is something that I hear all the time. I came across your journal article on the prevalence of mental health disorders in adults with CP. I'm a nurse working in clinical research and have a 45-year-old cousin with CP. She only very recently started exhibiting severe anxiety and depression, and I suspect bipolar. I am looking to find a clinician specializing in adults with CP and mood affective disorders. Thanks for doing this important research. While it's nice to receive comments like this, it's also sad to me, because I am unable to provide recommendations, simply because there are no trained professionals who both are trained in mental health and CP. And we can do a better job, is what I'm saying. We can do a much better job, and hopefully with our work at the foundation, we'll have the platform and opportunity to give the tools, I suppose, to everyone, and provide a toolkit by which doctors and their patients can come together and agree upon a set of guidelines and a set of resources that we will hope will grow with time. Okay, we can just skip over this. This is the same thing. We're just essentially saying the same thing. One of the, yep. Good. One of the things that we know is a classic or hallmark symptom of CP is pain. And pain management has been in the Wild West. I hate to say it, but like everybody who treats pain does it differently. And we are trying to create best practices for how to treat pain. But clearly we know pain, especially chronic pain, is associated with mental health issues as well. And so you cannot remove one without, you know, doing something to the other. And you cannot think about things in silos. And so thinking about the whole person, we have to treat pain and mental health, but I do think that pain is a contributor of mental issues as well. I mean, even for my own self, having pretty significant low back pain with sports participation, that has been a serious issue for me over the course of my life. But having pain from the time of childhood all the way through adulthood is certainly going to be a contributing factor for mental health issues. So we wanted to look at and explore maybe some of the potential links between pain. And typically speaking, not that anybody cares about the different types of pain, but if you do, because maybe you have different types of pain, pain is not a yes, no question. Pain comes from different sources inside of your body. You have what is typically thought of a painful injury, for example, like a torn ligament or muscle strain. That would be a peripheral pain or what's called a nociceptive pain. That is the only type of pain that has ever been studied in CP. Nobody has ever thought about anything but, you know, what happens with spastic muscle, what happens with joint dislocation, what happens with a torn rotator cuff or you know, a gastroc tendon lengthening procedure. So nobody's ever thought about anything basically but that, because essentially orthopedic surgeons have run the show from pain management. But it turns out that pain can come from other places. It can come from a neuropathy, which you probably have heard. That's become a big word now. Neuropathy can come at essentially any part of the nervous system, both central or peripheral nervous system, but it is either an entrapment or damage to the nerve or a disease that causes the nerve to be compromised in some way. And then lastly on the list is a new type of pain designation, which is not new, but it's new in terms of name. It's called nociplastic pain. It used to be called fibromyalgia, which everyone has heard of. And now it's a centralized sort of central mechanism of pain that comes from the brain and central nervous system. So we are starting to think about pain in a drastically different way here at the University of Michigan. I think we're starting to get some traction at other locations to consider pain from where it's coming from, and then that would lead us to better ways to treat it. Because as you'll see in a minute, the blunt instrument of pharmaceutical pain treatments like opioids is a real problem, and it is something that I think that we can do a better job with. Essentially, the last couple of studies that I have on the slides here is showing that adults with CP, it says adults with CP and spina bifida only because we built two cohorts of individuals who have either CP or spina bifida, and I don't yell at me. Those are dramatically different patient populations with totally different disease etiologies or causes, but there are certain features about both that resemble each other, especially in adulthood. And pain is one of those, and the type of pain is also one of those. So what we found was that for folks with CP or spina bifida, there was a high prevalence of all types of pain. And those were all very, very significant, even after adjusting for many other things that can cause pain. So people with CP have a high prevalence of all peripheral, nociceptive, nociplastic, and neuropathic pain. And I think this is important as again, another first study of its kind, because it helps to shed some light on why folks come to our clinics and say, I have pain here, 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 here. It's not just pain, yes or no. It's I have pain in 14 different sites. And that's more common than saying, I just have knee pain, or I just have knee osteoarthritis, or I just have back pain, which is more typical in a non-CP population. So if we're gonna advocate for folks with CP to be seen by a pain specialist, I don't want those individuals walking into the door and saying, and another thing about adults with CP I've learned is that they are tougher than the general population, much, much, much tougher actually. And so normalizing pain seems to be kind of usual. And that is something that I think is a disservice because now as a result, pain is not being treated appropriately. So I think it's important to look at the type of pain and the location of pain. All right, so we did a Michigan study to look at the type of pain, and so you can go to the next slide. And what we found was that adults here at U of M, and this is not specific to U of M, obviously, but there were a mixed, we call it phenotype, but a mixed type of pain. So the vast majority did not have only peripheral pain. That's the blue pie, all right? To make it very simple, the pie represents 100%. Only 39% of people seen in our clinic had what we would consider to be a classic peripheral pain. So that's a classic like knee pain, joint pain, muscle spasticity type pain. Everybody else seemed to have sort of the vast majority had a mixed phenotype of pain. They had pain that came from different mechanisms, whether it be neuropathy or centralized pain. But certainly the centralized pain seems to pique our interest because it has, if you go to the next slide, Katie, it has a greater signature or greater association with self-reported quality of life. So we use tools to get at things like depression, anxiety, and folks who score higher on our centralized pain score have also higher risk for developing anxiety and depression. So again, nail in the coffin here, we need to be thinking about the type of pain and then aligning treatment with the type of pain, which has typically not been done in the United States. We've done a number of studies over the last 2 years. This is just one of them. We published another one just a little bit ago to look at opioid prescription patterns. And opioids are effective. There's no question about it, especially in a perioperative or after surgery time period to treat pain because surgery is painful. So opioids are useful in that context, and it is very appropriate to use pharmaceutical agents like opioids and other things to treat pain in the, after a surgical procedure is done. But the problem is what we're finding is that physicians don't know how to handle this. And so they're doling out opioids for our population at a much higher rate than the general population is being exposed to. And I don't per se blame people for how their practice is oriented, because sometimes there is confusion, and that's our whole goal at the foundation. And my personal work is to educate not just consumers and stakeholders like yourselves, but also our clinical colleagues. And I think I'm biased a little bit about our academic institution at Michigan that would do a good job, but perhaps there's doctors out in the field that don't know necessarily any better, and they're prescribing opioids without great reason to do it, which, if you don't know, opioids can have a really huge effect on, mental health, respiratory health, bowel and bladder function, risking fall and fracture. And so while it's effective in the short term, it has some pretty negative effects in the long term. So trying to help with reducing some of that. So I don't need to show you the actual data, but the folks who have the highest amounts of pain receive the highest amounts of opioids in our population. And I'm trying real hard to crack down on that. So you can skip to the next slide. I think this is the last study. This study was published last year in a fairly prominent journal, JAMA Neurology, where we looked at the type of pain in Medicare beneficiaries with adults with CP. A large percentage of the CP population has either Medicaid or Medicare, and so it's important to understand the extent to which those folks have pain and how they're being treated. So you can skip to the next slide. What we found was previous estimates about how many people who are adults with CP who have pain was around 75%. What we found was that in our cohort study, which is the largest ever, actually, is that almost 90%, 89% had at least one or more documented pain diagnosis, and only 11 had no pain. We found that 15% had a single pain diagnosis, which is a pretty small number considering that there was 89% of people with pain. And so about 74% exhibited pain multimorbidity, that's 2 or more, and 29 or about 30% had extreme pain multimorbidity. So that's more than 5 or more diagnosis, basically diagnostic codes in the claim that they have pain in multiple areas. And then again, the distribution of the type of pain was diverse and mixed, showing that there was a high prevalence of nociceptive, but also neuropathic and nociplastic centralized pain. So we are currently trying to extend our work into the long-term consequences of opioid use, and trying to come up with alternative strategies, both behavioral and interventional strategies. One of the things, because I can just allude to it, because you guys aren't going to rip off my ideas, is that sleep hygiene and physical activity are some of the most potent treatments for pain, especially chronic pain. Sleep disruption and lack of physical activity seems to really amplify the pain experience in all adults, not just folks with CP. We need to come up with better preventive screening to reduce preventable morbidity. Screening is the only way you know what's going on under the surface. So if a doctor's not doing screening, and I will tell you right now, that includes bone mineral density scans earlier than what the typically developed non-CP population gets. I mean, essentially demand to get a bone mineral density scan, or change your doctor, is my recommendation. We want to reduce healthcare disparities across the lifespan by improving care coordination and hopefully educating more up and coming and trained doctors. And then, of course, last but not least, the big deal here is developing our clinical practice guidelines. This is a little bit old now slide, but the title of this group is Cerebral Palsy Grows Up, and it's basically from the work that I have been doing. And this paper was published a few years ago in Mayo Clinic Proceedings, which shows that, not just do children with CP grow up, but the state of the literature has grown. This represents a graph starting from 1952 to 2024. That's October 3rd of 2024. What the number of papers published that have anything to do with adults with CP. Now, this doesn't have anything to do with health in adults with CP. This is anything to do with adults with CP. So in the last 6 years, I want to say, is a roughly 80% of all papers ever published in the history of the world about adults with CP. So we're talking about 6 years. So this is really in its infancy, and is to me very positive, because it shows that there has been a big impact in the world about the lifespan initiative, which is just great. And again, I really appreciate the support of the foundation to help out with this project and really push this forward as an important objective. You can go to the next slide. The last slide is it's hard to read. I'm sorry. We just published this in Developmental Medicine Child Neurology. I don't want to talk about our federal government right now, because that's another topic for another day. And I don't want to get started on that, but the NIH portfolio for cerebral palsy is pretty small by comparison to other conditions like autism and obviously cancer and stroke, but it's too small. Federal funding for CP is less than $30 million a year. And if you can see the pale green line on the very bottom, it is less than 3% for adults. So, all of what I've said is good in terms of traction and movement in the right direction. But we really have to advocate. And I know there's folks at the foundation who are doing a lot of advocacy work, and I hope that we can move the needle a little bit. And it may not happen for another 3.5 years, but let's hope at some incremental point that we can have an effect on advocating for improved funding at the NIH and other federal agencies to improve, especially lifespan care for CP and other neurodevelopmental conditions. I acknowledge my funding and also the help of the foundation, and go ahead and skip 2 slides. Yep, the CP Foundation. This is Marcus. There's not a good current picture, but here's some pictures of Marcus with my son. We enjoy sports a lot. He does adaptive biking. That little picture up at the top left is when he first started biking when he was a little guy. He's 15 now. We do a lot of U of M sports. He does biking, he does horseback riding, he does adaptive tennis, he does adaptive basketball. He loves Special Olympics. He does Special Olympics basketball. Yeah, we go to a lot of University of Michigan sporting events. He does kayaking, although I will say he sits in the front of the boat and doesn't paddle. So I don't know that he's getting any physical activity there, but he does love going out with me. So thank you very much for your attention. Hopefully that was useful and not a waste of your time, and happy to take any questions either now or at the end.
Thanks so much, Mark. Yeah,
I think
we'll take questions at the end. We're just as appreciative for your dedication to our community, this work. And I think what you're showing here with your son is that movement is important for people with CP. That's at least what I've picked up on here. So anyways, well, we won't spend too much time on this next section. I do want to make sure we have ample time for questions, but really, what we've been hearing from Ashley and Mark is a lot about the research, a lot about these clinical practice guidelines and the domains that will inform them. But I think what's key to this is making sure that from a knowledge translation and dissemination perspective, we really have a duty to our community to make the research and make the language accessible and easy to understand so that these clinical guidelines can be actually implemented into practice for both patients like ourselves and providers. And we have a responsibility to get the information out there in a way that makes sense to us and our peers, right? And so from the community survey that we led a few years ago, we really learned that people are just seeking information digitally. And so that really underpinned our entire project strategy. So number one, we are developing a really unique digital ecosystem that I'm super pleased with so far. We have a brand within CPF. We have a whole digital home. I just wanted to highlight here really quickly. We have a website that we're building out. We have a growing Instagram account. We have a podcast. And number two, I just want to highlight video series. So all of these things that you see here, just kind of high level, how this project will really help inform what the clinical practice guidelines are not only covering, what break down the systematic reviews, but also how we can use them as a tool in our own lives. So we're doing that through, everything that we do share with you will have a home on the website or Instagram account. That's pretty much our main homes right now for CPG related content. We're developing a community-based video series highlighting disability and womanhood, featuring Ashley and a few other amazing women from our community, as well as a forthcoming video featuring renowned CP researcher and neuroscientist, Dr. Kathleen Friel. So keep an eye on our Instagram and probably our YouTube as well for that. And then our podcast, featuring really candid conversations with experts in our community, people with lived experience, professional experience as disability advocates, activists. Season 1 is available wherever you get your podcast, so definitely binge listen. Season 1, if you haven't already, let us know what your favorite episode is. We'd love to get some feedback from you as well on what you're looking for. Season 2 will really be driven by conversations that really highlight the clinical practice guidelines through these systematic reviews that we'll be publishing throughout 2025. And so, like I said earlier, it's really about breaking down the research into information that's easily accessible, easily understandable by everyone in our community, especially those like myself who don't have medical degrees and can unpack, Mark's article. And then also, we'll be looking for your feedback all along the way. So definitely keep an eye on our Instagram, respond to our Q&As and polls. We just really love to keep you engaged along the way and give you opportunities to get involved in research and anything we've got going on. Lastly, I don't believe this is live yet, but we will be publishing more information on the first systematic review pain that has been published. We'll give you a link to the full text, so you're welcome to read it yourself. We'll break it down with this pretty easy to understand graphic. Anything related to the systematic review will each kind of have its own home on our website. So once all 10 are published, you'll be able to access all of that there. And then lastly, this webinar is the kickoff of our quarterly conversation series that we would love to have you on throughout the year, and invite you to dialogue on topics that our community cares about. So feel free to also make your suggestions here and on our Instagram. And then early in 2026, it's our goal to host the first ever CPGU healthcare conference for adults with CP, so that we can have an in-person opportunity to get together and just talk and understand how we can bring the CPGs into our lives and into our practice as patients and healthcare providers. I think that's it. Definitely give us a follow if you haven't already. And we'll save a few minutes for questions.
Amazing. Thank you both. There are a couple of questions and comments in the Q&A already, but if y'all have got more, now is the time to drop them here. Mark, somebody mentioned that the process that we're doing is very similar to what the Spina Bifida Association has done for their care guidelines, and that they're happy to see that. I know that was when we thought about how to go about this, looking to that as a blueprint was part of that whole process.
Yeah, I mean, developing clinical practice guidelines is very hard, I will say, and laborious, and takes a very long time. And what the folks of the Spina Bifida Association has done is it is a blueprint. There's other various patient populations that have very specific clinical practice guidelines, and there are for CP, but they are all in pediatrics, and so they're mostly around CP symptom management. And the goal here was really to look at the whole person and to consider what happens to individuals in the context of sort of overall health. And I do think that is what we've accomplished. That's what we are accomplishing. And I'm glad that other populations, spina bifida being one of them, has tackled that as well. But I do think that for CP, this is a first of its kind and will be hopefully a game changer.
Then we have just some more folks just saying, thank you for your time and expertise and energy going into all of this, which we all really appreciate hearing. We care about this a lot, but it can sometimes feel, I'm not quite sure what the word, it feels like fighting an uphill battle sometimes for just like the bare minimum of action and progress across this field. But we really are, we are working hard, and this is still very much new at the work that we're doing as far as the foundation goes, and how to put this stuff out here. So we're not going to get it right 100% all the time, but we really are trying. And I think you all can kind of sense that everyone behind this is really invested. And there are a couple of actual questions, so I'm going to run through a couple of these. But one of the questions is, how can we help advocate for ourselves when going to the doctors? I feel like I hit a wall when I question things that are going on with me. Well,
I feel like you both could probably answer that better than I. Here's the thing. I mean, without information, there is no way to advocate, because I mean, no offense, clinical practice works in a very recipe way. And if you don't add to the recipe, they will not deviate from their clinical practice that they have been trained on. So the hope here is that if we develop these guidelines, and then we develop resources that are, I guess, are outward facing, that you can use to put in front of folks, or you hopefully won't have to. We will jam it down their throat. They will be equipped. And the other thing that I think is what we're hoping to do with the foundation support is to develop fellowships. So, when a doctor goes through medical residency, they then will either not or do a fellowship and a specialization. And what has never really happened is a specialization in treating adults with pediatric onset neurodevelopmental conditions. And so the same thing can be said for autism spectrum or spina bifida, is that there are no fellowships for adult providers for these conditions. And so they rely essentially, to give you the sort of the dirty details, they rely on maybe a pediatric rounds that they did in neurology back in medical school, which may have taken place over a month, and they don't know. So we think that we can develop the guidelines, but then we still have to do something about medical education. And that's the hope, is that we can do this. We can develop this toolkit, and then we can move on and say, we've created the Bible. Now let's go into medical schools and train people in, and actually understanding how to treat. Because right now in 2025, people are living longer lives. Medical education and medical advancement has taken place to such extent that adults with CP and other neurological conditions, neurodevelopmental conditions, are living longer and very, normal lifespan. So it is going to be a very important addition to medical education to add this to, and from what I've seen from residents, there is a demand for it and interest in it.
Yes, and I will say that, as a part of the project specifically, in addition to the guidelines and in addition to the education that will come as a part of the clinical implementation process, we are also hoping to fund, y'all everything's fund independent, especially when you're a nonprofit. But over the next few years, an adult advocacy collective that would use a curriculum to teach adults with CP how to self-advocate within the medical system and the healthcare system, and how to navigate through that, as well as advocacy skills at the more in the more advocacy and policy space around like funding and change on those levels. So we're hoping that in the next 3 years to develop a curriculum that can be used to sort of accomplish both of those goals. And as far as a couple of other of these questions is, let's see, there was a really good one just here. Many diagnostic tests require people to remain still, even though, even like getting an accurate blood pressure reading. If we're unable to stay still, how do we get tested? And I think that just speaks to the inaccessibility of medical spaces, the places that should be most accessible to all. That one's tricky. It's hard to not be able to get what you need, and I don't know that there is a good answer, which is why I picked this question. It's not necessarily because I have the answer to it, but it is illustrative of why all of these different components are needed, right? Why guidelines are needed, why provider education is so desperately needed, why physical space access is so needed, why advocacy skills are so needed. I hate that I don't have a better answer for how do I get a better blood pressure reading. But what we can do is try to continue to advance work that is addressing these issues across all those fronts.
I think from this is my non-expert opinion. This is I have CP2 and I'm just navigating this as much as anyone else. But I mentioned to my physical therapist that the CPGs are coming soon, and however many months away. And I asked her if I could send them to her, and she was absolutely enthusiastic about it. But I think it's okay to challenge our providers a little bit to learn about CP in their own time, invest a little bit of energy into your care as their patient if you have an ongoing relationship with them. I think that's a very fair kind of request to make of a person that you're seeing for a very specific thing. And to just inform them of things that you know are happening in our space. Have them watch this webinar when we post it. Just feel free to kind of speak up to that degree. That's kind of the approach that I've taken.
Yeah, the number of times I've heard a patient say that they went to a facility that didn't have a bed that they could get into is, I mean, countless. So it's not just blood pressure, it's not just bone density or imaging. It's virtually all screening. And I'm not an engineer, so I can't answer the question, but I can validate the fact that that is a legitimate problem that has not been addressed adequately.
And Mark, I'd like to get your take on this one. What's your best advice in terms of communicating with doctors for those of us who are middle-aged or older, who are already starting to encounter the impacts of CP and aging?
You know, we have to create those resources, Ashley. Honestly, we have to create the resources that are, you know, doctors are, they have limited time. And so again, they do CME. Maybe we start working in the CME area as well, because they have to do continuing medical education in order to keep their license. If we started to do some of that, and I do think that we have to equip, I really hesitate to say, like, we have to equip people with information so that they can bring it to their doctors. We do have to do that, but I want the doctors to be ready for when people show up. That's what I actually want. I don't want our patients to have to educate doctors. That seems like a really backwards way of doing business. What I'd like is for doctors to be ready for when a person comes into their room and they know they have CP and they have these potential areas of risk. And that's what I want. If I do nothing else in my career but to equip doctors to handle any person with CP who walks into a clinical environment, to be ready for them, then I will feel like I've done something, you know, quality of work.
Same here. I think, you know, the mental load of living with disability and living with CP, it's already pretty high.
You shouldn't have to do anything else
and-
besides that.
Right? You know, we deserve to
Wishful
just
thinking.
doctor. Yeah. But I think, you know, what we can tangibly do in the meantime, as we work towards, Mark, our shared ultimate goal, is we can produce resources that folks can take. We can produce continuing education materials. And that's all the part of the CPGU plan. It's just going to be, if I'm, you know, being honest with y'all, it's a slow roll. We're a nonprofit. We are a small team, and we are doing things at the pace we can, and we're just as eager for it to happen as you. So I think the development probably over the next like year to 2 years of these kinds of resources will make a dent in this kind of thing. I know it will.
It's definitely going to make a dent. It's already made a huge dent, and people are starting to change. The number of physicians who I know worldwide, actually, I have a lot of colleagues around the world who have said they're changing their clinical practice on the basis of our work is going up exponentially. So it is making a dent for sure.
Just looking through. We've got some similar questions, so I'm just making sure I haven't missed anything.
Someone's asking about providers at the University of Michigan in particular. Should I try to get anyone specific on my care team? I think is what they're asking.
At Michigan, I will tell
Yeah.
you that because we are one of the only adult clinics in the country, there are a few, but because we're one of the only adult clinics that does I will say semi comprehensive care. We have people that come from every state, including Hawaii. So I was shocked to find out that we have a client, we have a patient from Hawaii that comes in that will stay for a few months. But what I can say is that our clinical care, who is run through PM&R and physiatrists, will also expose people to therapy. They will put in referral to mental health. They will do multiple things while person is in-house. I don't necessarily advocate for people to fly into the University of Michigan. I shouldn't ever do that, because there are good people in all states, but there are very few adult clinics around the country. That's one of the things that we'd like to accomplish with the collaboration with the foundation, is that we start adult satellite clinics in various regions throughout the US that can help. But right now there's just not a lot.
That's the whole clinical implementation
The implementation piece.
project. Yep, that we'll be unfolding for y'all in more detail as we get further down the road. But I do know we're coming up on our time. And I know if you're on the East Coast like me, it's getting a little bit late in the day. And I just want to be respectful of everybody's time, including y'all's. And we just thank you so much for joining, for asking questions. There was a question in here about how to support CPGU. There are donate links on our website. I don't really feel great about asking our own community for monetary support. Like, y'all deserve this more than anyone, but if you have folks in your network that you want to pass that along to, feel free. We are going to be launching merch this week as a fundraising mechanism, so keep an eyeball out for that. And if other ways that you can support her, just come to our events, share our posts, help us tell as many people. Right now our audience is very centered on adults with CP, which is exactly who this project is for. But beyond that, we also want to be bringing other folks into the fold, be that parents, family members, spouses, researchers, clinicians, anybody who has a vested interest in this topic. So just sharing and supporting and joining in. That's all we can ask for. But y'all are great, and we'll be doing at least 2 more of these discussion series this calendar year. So keep an eye out.
And Ashley, feel free to share my contact information. A lot of people don't do that, but I'm an open door. So I'm being honest. Please share my contact information.
Absolutely. We can figure out a way to do that. All right. Thank y'all so much.
Thanks, everyone.
Thank you. Thank you so much.
Have a great evening. Bye.